I have the pleasure of introducing Dr. Marcus Westerman for one of the hospitalist assigned grand rounds of the new year. Welcome to 2017. Dr. Westerman is a board-certified psychiatrist with specialization in child and adolescent psychiatry. He's a graduate of the University of Minnesota. Although prior to this beautiful building being constructed we were talking about, he completed his adult psychiatry residency and a child and adolescent psych fellowship also at the U of M. Dr. Westerman is a member of the American Psychiatric Association and American Academy of Child and Adolescent Psychiatry. He's been treating children and teens and young adults with eating disorders at the Melrose Center for the past 6 years, which is what we're going to be talking about today. Welcome, Dr. Westerman.
All right, can you hear me? All right. So we were talking a little bit earlier. This is a bit of a homecoming for me. I haven't been in this new building, but I did my residency here. So I was just walking around, and to this day, I cannot go by a Subway without having like flashbacks of doing residency and stuff here. I just walk down, and you get that waft of like Subway smell. But yeah, I was at the U I joke sometimes, for 19 years, because I did my undergrad here. I went to grad school in neuroscience here, and then med school and residency. I thought about moving around, but through the process of all that, I had a bunch of kids, so yeah, didn't really decide to move. But I'm going to talk a little bit about eating disorders, primarily in kids and adolescents. I don't have any sort of financial things. Overall, in terms of objectives, I'm going to try to keep it a little bit simple. You know, if there's questions or things that come up along the way, just let me know. I'll try to be a little bit more, or a little less or a little bit more casual about things. We'll talk a little bit about just defining eating disorders. There's been some changes with the DSM-V, which I think are particularly important for kids and adolescents. Basically what happened is they found that the vast majority of people were being diagnosed with what we call EDNOS, which means, you probably heard that, eating disorder not otherwise specified. It was something like 70 or 80%. Well, then the actual diagnoses are not really serving any purpose if everybody is sort of falling into this not quite fit in any other category. So we'll talk a little bit more about that. Signs and symptoms of eating disorders, what to look for, when to screen, when to refer, understanding eating disorders a little bit, their treatment and prognosis. The thing that I think is really important, and part of the reason I do what I do, is because eating disorders are really not about body image. They're really about biology. There's a huge part of these disorders that is about poor nutrition and starvation and all the symptoms that go along with that. There's sort of classical and sort of stereotypical ideas of what really drives eating disorders, but when it comes down to it, it's really the biology of things that drive it. And that's a huge part of one, diagnosing, but also in terms of treating. We'll talk again a little bit of what to look for, what to do, and just a little bit of a better understanding. I think one thing that's really important in terms of this idea of the biology is that, what does an eating disorder look like? I think we have different impressions in terms of what we think of as stereotypically eating disorders. And it's key to know that anorexia is the highest mortality rate of any psychiatric disorder. So this sort of scares people off sometimes, but I think the crucial thing to understand, again, is that these are really serious, really severe, really important diagnoses and illnesses to treat, and how we do that is very medical. That's why, again, that's what drives my interest and sort of passion for identifying eating disorders early, understanding what they are, and how to treat them. In terms of what we think about with eating disorders, for females between 15 and 24 with anorexia, the mortality rate is 12 times higher than the death rate of all other causes of death at that age group. But also eating disorders affect growth. If a person doesn't eat, they do not grow. This includes brain development. And I would say eating disorders are sort of a black hole for life. One of the key sort of components of kind of the social and psychological aspects of recovery is really establishing a life outside of the eating disorder and not allowing it to basically suck away all of that childhood and adolescence. Again, in terms of talking a little bit about the DSM-V distinctions, we have, the classic anorexia nervosa, bulimia nervosa. Some of the criterion have changed a little bit for that. With DSM-V, they've also added binge eating disorder. And I'll talk a little bit about this and also kind of how to talk about eating and weight with kids in general, because I think now as pediatricians, as medical providers, you're kind of getting this pendulum swing. On the one hand, you want to talk about things like obesity and the health risks that go along with that, but at the same time, you don't want to pendulum swing people into over concern about weight and eating into kind of eating disorder category, because we're seeing a lot of that these days, that kids are presenting with, oh, I heard in health class how this is so bad, and we're counting calories, and we're doing the my fitness app and all these things to kind of pay attention to what I'm eating because everybody's so concerned about obesity, and that's kind of throwing people in the opposite direction. The other thing I think is important to talk about is something called avoidant restrictive feeding disorder. This is something, again, I think as providers for children, we all know what it is. Every doctor, whenever I go to outside clinics, primary care clinics, pediatric clinics, they all see these kids all the time, and nobody really knew what to call it. And so we'll talk a little bit more about that. So I use this as an example because this was one of my first patients that I ever had working at Melrose. I had a 12-year-old male. He was very athletic. He was a soccer player, small stature for his age, kind of presented irritable. Parents didn't really know what was going on. He was more withdrawn, grumpy, rigid about his eating healthy. Again, it was one of those things that his coach had said, hey, we want you to be more physically active. We really want you to eat these kinds of things. And it just kind of went more extreme. He wanted to exercise after eating. He felt very uncomfortable when he was eating. And we'll talk a little bit more about that sort of physical aspect of things when kids stop eating and what happens. And I always found it interesting. He described to me a very nice kid, but he would stop at the grocery store on his way home, biking home from school or from soccer, and just hang out at the grocery store. I mean, what 12-year-old kid hangs out at the grocery store? He wouldn't get anything, wouldn't eat anything, just wander around. A starving kid. I mean, that's what happens. These are things, again, I always say, our brains are very arrogant. They tend to think that they know more than they really know, that they're in control of everything, that everything is logical and everything makes sense. But we have to keep in mind that these things are driven by your biology, what's going on with your system. So, you have kids who start to read cooking books or watch, HGTV all the time, or all these things that go along with your brain sort of focusing more on eating, even though that's not something that you consciously want to do. More typically, you might have a presentation of something like a low heart rate, always feeling cold, lethargic, and something typical of, a low BMI. So with anorexia, it's really classically seen with persistent restrictions, significantly low body weight. But I think the important thing, especially with kids, is that it's not just low body weight. It also might be sort of a failure to thrive, a failure to gain normal weight. There can be an intense fear of gaining weight or becoming fat, disturbance in the way one's body weight is experienced. We call this sort of cognitive distortion. So these are the kids that say, look at my belly, it's sticking out, I always tell patients, whenever you use the word feel, okay, that's a red flag. We're not going by what you're feeling. So if you think about it, if you have a system that's not eating regularly, your GI system is basically a big donut, this sort of conveyor belt that's going through your body, and if it's not being used, it slows way down. So what happens when it slows down? You get constipation, you get heartburn, you get full quickly, your stomach sort of, I always describe it as kind of shrinking up, although we know that's not really how it is. But, you get full, you eat a lot, and your system just doesn't feel comfortable. So we call that feeling full, right? When you feel full, what do you feel like? You feel fat, right? I mean, you have a turkey dinner, you want to go lay down on the couch. But the reason is, your body has this natural signal to go lay down, be less active, digest your food, right? That's what fullness is. It's our body sort of preventing us from going out and running around and that kind of thing. Well, for whatever reason, our society sort of has such a negative connotation with weight that when we feel full, that sort of pulls us into this worry about being fat, right? So even the word fat can be just so negative. So when a kid is sitting there and ironically, the fact that they're eating less is making them feel full quicker and more often, right? So they feel fat all the time. And they have this cognitive distortion about what their body actually looks like. I mean, if you look at yourself in the mirror when you get up in the morning before breakfast, you're like, oh, okay, looks good. If you have a big breakfast, you're, oh my God, I gained like 20 pounds, right? I mean, could you actually have gained that weight within a few hours? Absolutely not, right? Weight gain is an incredibly slow process. Even when we have people in inpatient units, we might have them gain a pound or 2 or 3 in a week with a significant increase in their intake. So the idea that you could somehow gain 5 pounds after a big breakfast, no, it's not physically possible, but it's very mentally possible. You feel very full, you feel very fat. And so that results in a whole different perspective. I mean, I don't know if any of you are old enough to remember like after school specials, where they sort of show, okay, this is the person with the eating disorder, and they look in the mirror and they look like this big fat person. It's not so much that, it's that our brain's perception of what we look like is different. It doesn't actually change what we're seeing, we just perceive what we're seeing as being bigger. Does that make sense? Some of the signs and symptoms, things to look out for. Obviously, things like bradycardia, low blood pressure, falling off the growth curve. We'll talk a little bit more about that later. But I think that's an important thing, because if you have a kid coming in and their BMI seems fine, but their growth curve has switched, that's a big red flag. Lanugo, refusing to be weighed in the clinic, more sort of sensitivity about it, being dressed in layers. I call this sort of sweatpants town, where you have a kid that's wearing sweatpants and coats and not wanting to take them off. Another thing that I think is underreported is sort of pacing, constant movement. I always think of it as like, especially in younger kids, your body sort of wants to be out looking for food. So there's a lot of what we call perching. They'll go to school, they'll sit and they'll perch in their seats, they'll sit really stiff and they'll move constantly, because it's, again, this body's sort of natural response to starvation. For bulimia, in terms of looking at things officially, really what this means is recurrent episodes of binge eating, and then, which is defined a little, we'll talk about this as we go, a larger than what most people would eat. So we have a distinction between what's called subjective binging and objective binging. And I think this is important to know as clinicians, because subjective binging, you'll have a lot of kids coming in and saying, yes, I'm binge eating. And they might be saying that in response to, I had a Snicker bar for lunch. They feel like they shouldn't be eating that way. But objective is, yeah, that's a lot of food. No matter what anybody would say, you would understand that's a lot of food. And what's called sort of a sense of a lack of control. And we'll talk about this a little bit more with binge eating, because I think that's an important distinction. You have recurrent inappropriate compensatory behavior. So we think of this as purging. Classically, that would be vomiting. But I think the other things that I would want people to pay attention to is that purging can also be exercise. It can be laxative use. It can be use of diuretics. It can be use of other, I've had patients that take their parents' water pills and things like that. Fasting. Things, if you have a diabetic child, things like withholding insulin can kind of fall under that category. We'll talk about that a little bit later too. And this happens once a week for 3 months. And again, that same idea that the self-evaluation is unduly influenced by body shape and weight. Some signs and symptoms, it's important to keep in mind they can be any weight. In fact, it's actually most commonly associated with normal weight or overweight. So you can see problems with their teeth, enlarged parotid glands, and then we'll talk a little bit about labs. Hypokalemia is obviously a very important thing to look at in terms of concerning about bulimia. Laxative use, again, purging via exercise. These are just some pictures. You hear classically about Russell's sign, which has to do with inducing vomiting. You get calluses on the knuckles. The picture on the far left has the enlarged parotid glands. Sometimes you'll see edema, even to the point of pitting. This was one case I saw where she'd actually swallowed a toothbrush related to inducing vomiting. I believe that might have been here at the U when she needed to have it surgically removed. Talking about the avoidant restrictive food intake disorder, this is what I was talking about before, where you have a weight loss or failure to achieve expected weight gain in a child that's not concerned about body image. And again, I think this is something that as pediatricians most have seen and see frequently even, but we had never really had a diagnosis for it. Or a name for it. So they're avoiding food or restricting their intake for whatever reason. There can oftentimes be a psychosocial impairment, nutritional deficiencies, loss of growth, things like that. And there's sort of a bit of a gray area. I think sometimes we see a lot of patients that might fall under kind of the picky eating capacity where they have very limited variety. ARFID, or avoided restrictive food intake disorder, usually has some effect on what's going on with their weight. They're losing weight or not growing. Binge eating disorder, again, recurrent episodes of binge eating that are not associated with any sort of compensatory behavior. Again, the sense of lack of control, I always explain it as, it's not a feeling out of control as much as it is being out of control. Oftentimes, binge eating is sort of associated with an erratic eating pattern. You know, if you're not eating breakfast, if you're not eating lunch, and we see this a lot of times with kids, it makes sense that you would be eating a ton of food when you come home, right? I mean, your body is, to say that's pathological is hard to know, but obviously that can kind of go into a more problematic eating pattern. But I bring it up too because it is sort of a bit of a buzz thing going around. Do I have binge eating disorder? I would say most of the time when we have kids especially, we look into what is their eating pattern. Are they eating regularly? Again, if you're not eating a lot during the day for whatever reason, I see a lot of kids that might have things like ADHD or on a stimulant medication and they're binge eating at night. Well, okay, that kind of makes sense if they're not eating consistently throughout the day. Some of the characteristics of this is eating much more rapidly than normal, eating until feeling uncomfortably full or beyond that point, eating large amounts of food even when you're not physically hungry, eating alone because of feeling embarrassed or hiding. A lot of times we'll have parents bring their kids in because they're finding lots of food wrappers and things like that hidden in their room, feeling disgusted with oneself, depressed or guilty after these episodes. Again, there's no white criterion for binge eating disorder, no compensatory behavior. 30% of obese patients are binge eating, so that's a good thing to be screening for. Equal prevalence between males and females. Again, I bring up this sort of nighttime binge eating because sometimes we'll see kids for nighttime eating, and it seems to sometimes be related to using stimulants or things like that to treat ADHD, but also just kind of their regular eating pattern during the day. So again, when we talk about some of the causes, restrictive eating, either amounts, skipping meals, they're just not getting enough. And I point this out a little bit because I think this is a little bit more crucial with kids and adolescents than what you might classically see in adults. A lot of the times when we're actually talking to them about what their eating pattern is, that's a big part of it. The other big cause of binge eating can be food rules, restrictions. Hard rules break, flexible rules bend. So I call it sort of the case of the screw-its. If you say, well, I'm never supposed to eat ice cream and then I start eating ice cream, screw it, I might as well just eat it all. that kind of pattern oftentimes will come up and related to why those food rules and restrictions can be problematic. And again, sometimes this comes into some of the things that kids have within families. They have really hard, strict rules about their eating, and then they're hiding foods and things like that. Negative emotions and events, loss of inhibitions. I always, again, bring up things like eating and sleeping with kids, sleep deprivation. Chemical use can be a part of that too. I always say it's not a question of if, it's a question of when. So if you're restricting your eating, you will binge eat. You know, you gotta eat, you gotta breathe, you gotta sleep, you gotta poop. And those things, if you don't do them in the way you're supposed to, your body will make you do it in a way you don't want to. So if you don't sleep, you'll fall asleep in the middle of class. You'll fall asleep driving a car. If you have to go to the bathroom and you hold it, eventually you're pooping all over the floor, right? I mean, these things are stuff that is going to happen. So I think that relationship and understanding with eating and food is really crucial, especially with kids. All right. So then, you know, in terms of what to do, you know, a lot of times, especially in kids, the chief complaint is not usually an eating disorder. There's usually something else. They're irritable, they look like they're losing weight, they're not eating, I don't see them eating, they're hiding food, there's wrappers all over the room, that kind of thing. So who do you screen? Teens, sports physicals, college entrances are good places. The BMI is below 18, BMI above 30. An unusual or concerning weight change, and I think that's important to think about both loss or gain. You know, oftentimes bulimia can present as weight gain over time. Type 1 diabetes that aren't adhering to treatment, sort of multiple hospitalizations or DKA episodes, things like that. Patients with a substance abuse history, oftentimes athletes. I think, again, stereotypically, eating disorders may be associated with things like gymnastics or dance. I would say probably the most common these days is cross country. I'm a big runner, so I kind of understand, but at the same time, there's been a lot more focus on running and leanness related to that. Comorbid depression, anxiety, and I think this is important because, you know, I always say you don't try to eliminate anxiety in order to eat, you eat in order to eliminate anxiety. So this idea that oftentimes these kids may present in a more depressed, anxious, rigid kind of presentation may be related to the starvation, not necessarily being something that's causing the eating disorder. Does that make sense? General clues, sort of eliminating entire food groups. I shouldn't be eating this, I shouldn't be eating that. Skipping meals, I'm not hungry, I already ate. Lots of diet soda, gum, water, mints. Actually, gum tends to make you eat more, I think, technically speaking, because you have more saliva, so it induces your hunger more. So that's a bit of a myth. Isolation from friends, activities, eating erratically, lots of rules. I shouldn't be eating that, I shouldn't be eating this. Constant talk of food, weight, calories, exercise, things like that. Like I said before, things like reading cookbooks, watching lots of cooking shows. Not to say that, you know, I like Top Chef and things like that, but if you watch a lot of cooking shows, you have an eating disorder. Eating in isolation, hiding what you're eating, going to the bathroom or showering after eating is kind of telltale for things like purging. This is, again, a bit of an example of, you know, you might have a kid who has a BMI of 19 in pretty reasonable range, but the growth chart has gone from 90 to 10%. They might be passing out at school, might be more irritable, can't sleep, anxious. This is something I also kind of bring up because it's a bit, I think in sort of primary care and pediatrics, a bit of a concern sometimes. You have a kid that might come in reporting sort of classic symptoms of poor concentration, they can't focus in school, yet they're getting straight A's, they're doing really well in class, and they have this tachycardia and things like that. I always tell people, consider abuse of stimulants. That's become a bit of a rash nowadays, especially in sort of older adolescents, young college kids, where there's this idea of notion that stimulants might be effective in terms of weight loss, and they know what to say. And I don't say that in a negative way, I just say that in terms of when you're talking about these eating disorders and things like that. people are looking for, they're desperate for things that can kind of help. And I think it's also important to keep that in mind with binge eating, because again, stimulants might induce some loss of weight or reduce an appetite, but they also might induce binge eating because you're not eating well during the day. Another thing to look at in terms of LGBTQ population, as early as 12, homosexual teens may be at a higher risk of binge eating and purging. They're significantly more likely to have fasted, vomited, or taken laxatives. Homosexual males are 7 times more likely to binge and 12 times more likely to purge. We're seeing a lot of gender dysphoria coming up in terms of, I remember having a patient very significantly was restricting to kind of avoid female development. And when we got her into more support for gender dysphoria, her eating improved significantly because we were actually going down a track of making some of the changes that she wanted to make in her life as an older adolescent and adult. And it sort of pulled it away from, restricting her intake to avoid some of those developmental changes. I think it's important to kind of keep in mind too, and why do people not seek treatment? Things that you might hear, it's not a problem, I'm just very health conscious, this is normal. Or I think one thing that's more important is no one has ever asked. So, I've talked to kids that'll say, well, my pediatrician said that this is okay, or I'm at a BMI of 15 and they didn't say anything, or they hadn't had any concern about what was going on with my weight. And that's sort of perpetuated the problem that a lot of times the concern is about being overweight and not necessarily looking at underweight or sort of seeing that as healthy. It's been sort of their secret. They think they are in control, but really the eating disorder is in control. I think this is, if anybody that's worked with eating disorder patients, you hear this all the time. It's about control, and I feel like this gives me something control. Maybe I have a chaotic life and I'm controlling what's going on with my intake, but not really understanding that they're not really making the choices about what they're eating. A quick way of sort of screening is something we call the SCOFF questionnaire. So if you have 2 or more positive of these questions, it's good to maybe seek or ask further or seek help. Do you make yourself sick because you feel uncomfortably full? Do you worry that you've lost control over how much you eat? Have you recently lost more than 14 pounds? Do you believe yourself to be fat when others say you're too thin? Would you say that food dominates your life? Again, sort of a quick way to screen and see if there was a concern that might deserve further treatment. And this is what I was talking about initially. You're kind of stuck in a position. How do you start this conversation? On the one hand, you want to treat a kid and talk to them about good health and good eating habits and prevent things like obesity. But on the other hand, you don't want to go so far into throwing a kid who may be more vulnerable into eating disorder things. It's good to start with sort of a concerned, non-judgmental manner. Don't be vague. Ask specific questions. This is something I do all the time. If somebody comes in and says, we were talking about an eating disorder, I always ask why. What are you thinking? What are the thoughts that are going into this? What are you actually doing with your eating? What are you having for breakfast? What are you having for lunch? Say, I'm concerned about your weight. Let's discuss this today, even if it's overweight or underweight. Avoid placing shame, blame, or guilt on the person regarding actions. Avoid giving simple solutions. I think this is really important. Sort of not saying, well, you should do this, you should do that. Usually these things have a wider question and something that you should be looking into a little bit more detailed. Consider getting some collateral information from parents or people that came with them. Every time I see a kid, I call a parent if they're not there. Every time I see a kid for the first time, I bring the parents in. Because kid might say, hey, I'm fine. Parent says, no. So I think that's an important information to have, and you may not always be getting the full picture if you're just talking with the kid. Things like depression. I always say, depression is thoughts, it's emotions, and it's behavior. Your thoughts and your emotions, I have to get from you, from the patient. But your behavior, I can get that from parents and friends and things like that too. So that's an important thing to be looking at. How to talk to kids about their weight. Don't make it a big talk. Use sort of, in terms of talking to parents, have everyday discussions about nutrition. Make them feel capable, make them feel like they're a part of this discussion, not that there's something that's being done to them. Naturally, as a teenager or a young kid, you're not necessarily going to want to do everything your parent says, right? They may not. I would say, like, all of a sudden, my sons, when they got to be about 14, all of a sudden I became the least cool person in the entire world. Anything I said was the dumbest thing in the world, but if their friends said it, it would make sense. So my point is, like, you don't want to sort of sit them down and tell them on high what's going on, to say that you have some concerns and you want to be a part of that. Are they really overweight? I think this is a really important thing, because a lot of times I'll have kids that come in and say, my pediatrician told me I was chubby when I was like 10, and honestly, developmentally normal is there's a little bit of chubbiness that goes along with that stage. So oftentimes there is a little bit of what I call sort of a healthy understanding of kind of the degree of normal. No fad diets or supplements, nothing. I mean, what's the statistic? Like 95% of all diets, within the first year to 5 years, people gain the weight back. Diets don't work. Start small. I always say, make small changes. If you want them to be more active, maybe do something active as a family once a week, and then they enjoy that, and then they do it more. If you get a win, you have something that's changed in their life and something small, and I would say this is recovery from improving eating as well as, maybe decreasing intake too. Replace foods, don't restrict. So you start thinking about what can we have instead of the juice or the fruit snacks or something. We're just not going to have juice and fruit snacks anymore. Make it a family affair, stay positive. I would say sort of be a good coach. When we talk about things like eating disorder treatment, I always describe parents as being a coach. A good coach is going to, if you show up for practice and they say, hey, I just want to watch Family Guy on my iPhone and don't really want to do much today. If the coach says, okay, good, that's fine, right? Is that a good coach? Not really. I mean, they make you do things that you don't really want to do and feel uncomfortable about doing, but you do them because you need to. Make it relevant to them and their interests, and let them have control. Now, I say this in terms of, the talk about the improving sort of healthy eating. We'll talk more about the control thing in terms of treating eating disorders, because as parents, you actually tend to want to have more control in terms of treating things like anorexia and bulimia. I think this is a good quote. No kid ever lost weight because her mother told her she was fat. Right? I mean, that's kids whose parents talked to them about eating by focusing on their weight or size were more likely to adopt unhealthy eating behaviors, extreme diets, fasting, using laxatives, things like that. Kids whose parents focused on how to eat healthy and avoided judgmental statements about weight were much less likely to have eating problems. Avoid bringing attention to how they look or what their weight is, and rather talk about sort of healthy lifestyle. In terms of more, looking at what do you look for in eating disorders in the office, taking the EKG, looking for QTC interval changes, looking at electrolytes, particularly potassium, TSH, ALT, and AST. If you have a 12-year-old that has an elevated ALT or AST, that's a concerning thing. It's pretty common in anorexia. Also, cholesterol can be elevated. CBC, looking for anemia, bone marrow suppression. DEXA scans are something that we do not uncommonly also. Urgent referrals would be things like a low pulse rate, below 50, low blood pressure, orthostatic changes, weight loss. 15 pounds in 2 months is pretty extreme, or 10% in that period of time. Any purging is too much purging. Purging is incredibly medically bad for you. So if you're purging at all, Even if, a lot of times, sometimes kids will present with what I call sort of cyclic vomiting. They may not be intentionally purging, but they're sort of stuck in a cycle where they have struggles with nausea and things like that, and maybe vomiting more frequently. Again, a BMI of 18 or lower is something to think about. I bring up eating disorder and diabetes. We have a specialized sort of program at Melrose for this. You might hear of it as being called Bulimia. So it's kids that will eat or even binge eat and won't do appropriate insulin management. And it obviously very, very problematic thing and really important thing to be dealt with right away. So in terms of eating disorder recovery, what do you do? What's the important thing? This is where I talk a little bit about this being more of a biological process. When it comes down to it, I had a sort of a distant family member that just called me out of the blue, and he lives out of state and had a daughter that was struggling with an eating disorder and was sort of asking me, what do I do? I mean, what is sort of the main bullet point of what needs to happen? And what I would say is refeeding. You have to be focusing on what's going on with their nutrition. You have to get them the food, right? Regular eating, stabilizing weight. Again, this is where I think there's a bit of a stereotype in terms of, well, I always tell parents it's not about making them want to eat, it's about making sure that they eat even though they don't want to, right? So it's not something that you're just reasoning through. If there was some sort of statement that I could make that would say, okay, now you understand how important it is to eat, that doesn't work. This is not this is a starving brain. This is not a rational brain, and the first step really needs to be about weight stabilization, regular eating. But what also goes along with eating is exposure. So any treatment of anxiety, if you're scared of dogs, what do? You go hang out with dogs. If you're afraid of heights, you go skydiving, right? Anxiety is treated by exposure. It's not treated by Prozac or Zoloft or Xanax, right? Those are symptom management of anxiety, but treatment of anxiety, the key is exposure and habituation. If you jump in a cold lake, you jump out, you jump in, you jump out, it stays cold. If you jump in and you hang out, right, you chill for a while, you just get used to, your body accommodates to it. The temperature doesn't change. I always say, maybe it's an extreme thing, but all anxiety goes away, right? This is important. If you get swallowed by a whale, or you're in the Sarlacc pit or something in Return of the Jedi, and you're being digested over a week period of time, you're going to be really freaked out and anxious for about 15, 20 minutes, and then you're going to look for a book, right? You can get accommodated to anything. So eating is about making sure you're getting exposure and eliminating that food avoidance and anxiety. Breaking down food rules, breaking down the rigidity. So really, recovery is about food. In terms of how do we treat, FBT is sort of the default. So you've probably heard of family-based therapy. This is where I talk about, it's not you get a family in a room and we all talk about our emotions and family dynamics. It's you're making the parents the coach for the kid. You're helping them to coach them through and make sure that they're eating. CBTE is a more specific cognitive behavioral therapy for eating disorders. Now, this does come into play, and there's been some looking into how effective this is. Mostly used for adults and can be very effective, but there's been more recent evidence looking at sort of older adolescents or problematic families where more individualized approaches can be used. Best recovery rates are seen if weight restoration is seen within 1 month of starting intensive treatment. So this is where I go back to identifying this, treating it very seriously right from the start. Recovery rates are higher if treated within 3 years. There was I just saw this recently, there was a 20-year longitudinal study looking at recovery, and that a high percentage of anorexia and bulimia do have long-lasting recovery. I think this is, every time I've met with a parent and we've gone through everything, the part where I see them relax is when I tell them that this is not a chronic illness. all the time. That's a very small percentage of people. If you're identifying things early, getting treatment, my default is that you're going to get better and you're going to stay better. That's what parents, they need to know that. They need to know this isn't something that their kid is now going to struggle with for the rest of their life. If recovery is not seen in the first decade, though, recovery rates are lower. So again, it's important to identify and to treat. Binge eating disorder treatment, again, given that this is a little bit buzzy these days, again, for kids, I think the starting point is not Vyvanse, right? I mean, these medications have ads all over the place. Not approved for in kids. We'll talk about that a little bit later. But the first point is looking at what's going on with their eating. How are they eating? What are their eating patterns? Are they eating regularly? Are they skipping meals? If you're eating regularly, that alone will decrease the biological drive for binge eating significantly. Battle these food rules, improve variety of foods, emotional regulation, work on problem solving, food availability. I think that's, when we talk about things like obesity in kids, a lot of times it has to do with what we call food insecurity, right? I mean, these are kids that get up and don't have breakfast, don't necessarily have a regular lunch, come home from school, all that's around is chips and cookies. If your body is not getting adequate nutrition, it's going to go for what it needs: energy, fat, salt, right? When people binge eat, they don't binge on celery. They don't binge on chicken. They binge on chips and cookies and things like that, because you're trying to get what your body desperately needs quickly. So in terms of the medication side of things, again, this is more of an issue with kids and adolescents. I'm, again, more specifically talking about that. In terms of treating eating disorders for kids and adolescents, there is no approved medication to treat eating disorders. There is not a lot of evidence that medications are necessarily all that helpful. It tends to be the first thing that parents want to talk about. My kid is so anxious, we should treat them with this, this, and this, and that will get them to eat. That's really not how it works. When medications do come into play, it's mostly about treating comorbid things like major depression or anxiety disorders. Prozac, Lexapro are approved for treatment in children. Zoloft is approved for treating OCD. So a lot of what we do in terms of medication management is not about treating the eating disorder, it's about treating comorbid illnesses. That can oftentimes help. If depression, anxiety is really getting in the way of their recovery, that can be a part of the treatment, but it's definitely not the first line. We would argue that it wouldn't be the first line treatment for depression and anxiety anyways. Prozac is approved for treatment of bulimia in adults, but not for kids and adolescents. There may be reduction in binging and purging as well as preventing relapse. But again, this isn't the first line for kids and adolescents. We know that risks associated with SSRIs, things like increased suicidal thinking and behavioral activation, are higher in kids. I think, over the last year and a half, there's been more evidence that maybe this was even kind of minimized by some of the drug companies, and that there is a more specific risk for kids and adolescents, and I think that's important to keep in mind. QTC prolongation is always a risk. Yes, they'll have a black box warning for medications like Celexa, but it's a risk for all of the SSRIs, all of the well, not necessarily all of the SNRIs, but it's something to watch out for, especially with eating disorders, because it's one of the things that we see typically related to the eating disorder symptoms. So if that risk is made worse by an SSRI, that can be an important thing to keep in mind. Binge eating disorder medications, again, I think this has been a much more of a relevant thing recently. Diet pills, generally not effective. Cardiac risks are high. SSRIs, again, mostly it's related to treating comorbid depression and anxiety. Vyvanse has been approved for treating binge eating in adults. Again, it's important to keep in mind it was studied in overweight patients without comorbid psychiatric illnesses. So there's a lot of things to kind of keep in mind. It's not as simple as just starting a stimulant for a kid that's overweight, right? These medications have been tested as weight management medications and generally not been very good. But, there was a recent study looking at Vyvanse that it has been more effective long term. Other things like Belvig, again, this is for adults, believed to promote satiety. Wellbutrin, I would say, is most often used for treating depression, and oftentimes there can be an overlap in the sense that Wellbutrin is at least a medication to treat depression that isn't really associated with the risk of weight gain and oftentimes can be potentially helpful in terms of curbing appetite. But again, a bit of a gray zone and not really the first line treatment for kids and adolescents. Recently, there's a medication called Contrave that is actually just a combination of Wellbutrin and naltrexone. But again, we're talking about things that are approved in adults. Topamax can also have appetite suppressing effects and possible benefit for binge eating. I've had a couple kids that I've seen that have already been on trials of Topamax and things like that. Again, that wouldn't necessarily be the first line. We would want to get these kids in and talk to them about their eating pattern. All right. I'm losing. In terms of understanding eating disorders, I'll just talk about this kind of briefly, looking at time, because I want to make sure to have some time at the end. Why do kids get eating disorders? We don't. The answer is we don't really know, right? The sort of stereotypical things about is it parenting, are there other things going on, are all not true. There's potential genetic component. Anxiety disorders are certainly a risk factor. So it's very typical that these kids might have, I call it a little bit of an umbrella, that there might be overlap with things like OCD or generalized anxiety. And those things, if they precede the eating disorder, can oftentimes be an important thing to identify. I call it sort of the perfect storm. A lot of times it just starts off something fairly innocently. Maybe they heard from a coach or from a doctor about how to eat healthy, and that's sort of spiraled into eating less. They get less hungry. When you're eating less, you get full quicker, you're less interested in food. All those things tend to spiral down. And, I think it's important to kind of think about this as a biological engine that runs this. I always say we want to make eating disorders like to make things complicated. I like to make it simple. If you have something like restrictive eating, that can really result in binge eating. You have this sort of feeling full, feeling fat, poor body image. Your body can even go into kind of a storage mode when you're not eating well. You might purge to relieve that feeling of fullness, right? Again, purging is not generally associated with weight loss, but it certainly makes you feel like you're losing weight because you feel less full. There can be a stress relief, a sort of mood effect of that, a sedative kind of effect of purging. You might have guilt about what's going on with your eating, poor body image, desire to lose more weight, so that circles back into that restrictive eating. You can be, this whole process, if you're restricting more, can actually decrease metabolism, sort of set up a storage mode, which can even result in weight gain. So that engine is kind of driving this whole thing. With kids, again, you're going to be looking at these cognitive behavioral changes. Is there impairment at school? Do they have difficulty with decision making? There oftentimes is an intense fear of gaining weight, hyperactivity at times, poor sleep. I would say it's sort of a hungry lion sleeps with one eye open. If your body is not getting adequate nutrition, it wants to be out looking for food. The other thing to keep in mind is brain changes can persist for 3 to 4 months after an ideal body weight is achieved. So we always talk to parents and they tend to focus on, okay, once I get to the ideal body weight, things will all get better. I would say that's necessary. It's not necessarily sufficient. But you can't really do good therapy and work on some of these things with a starving brain. You can't argue with a starving brain. You can't reason with a starving brain. You can't work on emotions and body image concerns and all these things that can kind of feed into it if your brain is starving. And really the brain is under the influence of the eating disorder and doesn't really function in a rational manner when it comes to food and weight. I would say you're kind of colorblind, right? You can't see right now what is going on with your weight and what's going on with your eating. If I have a patient if I sort of quizzed them on what they thought their weight would be when they came in, I'd be a millionaire if I bet them on it, because oftentimes they'll come in and say, I know I've gained weight 10 pounds in the last week, and they've lost 3 pounds, right? They have no real good perception of what's going on with their eating, what's going on with their weight. An eating disorder brain, this is a picture of sort of adolescent females on the top with anorexia, and below, you can see the ventricles are much more enlarged, the brain is shrunk. You can't really tell me that these brains are working in the same way. A lot of times these patients will present as incredibly functional, smart, wonderful kids, wonderful families, but when it comes to eating and weight, they're really colorblind. They can't really understand, they can't even really tell you what's going on. There's a lot of increased irritability, depression, emotionality, rigidity, anxiety, self-harm, drama. It's always important to sort of monitor for suicidality, any sort of specific plans or recent attempts. Again, a starving brain does not function or act or interact in the same way. I think it's important, again, the biological consequences are potentially reversible with stabilization of a healthy body weight. So the sooner this happens, the less risk of long-term medical consequence, and treatment really helps. Just to kind of review, again, eating disorders are devastating in terms of impact on both mental health and physical health. Early identification, aggressive treatment are associated with improved outcomes. Sustained recovery is possible and likely. Treatment is most often involves the family and a multidisciplinary team. All right, questions? All right.
Nice talk. That was really terrific. Thank you. I've often been struck by the obsessive component in these eating disorders. I remember a colleague actually years ago who declined a piece of pie after a social function, and this person emailed me and called me and wanted to talk about that pie for months, really the most vetted pie in history. And it struck me that they had an eating disorder. And I wanted to ask you about OCD disorders. And is there, from the perspective of a psychiatrist, an overlap in these disorders, and does that tell us something about the pathophysiology of anorexia?
Definitely. When I was here, I actually worked for 3 years in the child and adolescent OCD and anxiety clinic with Dr. Bernstein. There's a lot of overlap, and I think that's actually a really important part of the biology of it. If you think about anxiety is your body feeling uncomfortable related to things being unpredictable, right? That's all it is. Your body wants to push you into making things predictable so that you stay safe. So OCD is really an exaggeration of that. So a starving body, a starving brain is under this constant stress. We talk about stress related to work and things like that, but if you're not eating, sleeping, breathing, pooping, the biological stress, the cortisol levels your body is constantly sort of basically convinced it's dying if it's not getting nutrition. So your brain's reaction to that is trying to make things more predictable, right? So similar as things like OCD. So that sort of rigidity, that OCD part of things is tightly tied to where things are with their weight, where things are with eating. And again, it's definitely a risk factor in terms of that overlap. I've often had, we talk about an OCD sort of symptom jumping. I had a patient once that washed his hands, and we got him not washing his hands, and then he started brushing his hair, right? So it can kind of hop from things to things. So oftentimes you might have an OCD kid where it starts to hop into food, and that can kind of get the ball rolling. But certainly as they're eating less, they're more restrictive, that worsens because the sort of biological stress with that goes through the roof. So the rigidity, it's kind of this irony because on the one hand you should be eating more, but your rules and your rigidity associated with the eating becomes much more severe.
So what about the young woman, adolescent, college student who just chronically keeps herself 10 to 15 pounds underweight, and she's not skeletal, she's not wearing big sweatshirts, she's wearing tight provocative clothes and is proud of that weight and getting a lot of social reinforcement for that weight. Aside from future risk of osteoporosis,
Yep.
what's the risk for that woman?
I actually bring this up a lot, that eating disorders are literally one of the worst ways to manage weight, right? So what this sort of, I think a lot of times will have, young women that will kind of say, well, I have this buffer. I want to be 5 to 10 pounds under. That means I can kind of eat anything, or like that it's a safety zone. But actually being underweight puts you at a very high risk of becoming overweight. And I know that might be something to bring up in terms of, because that can be really scary to some people, that, again, weight doesn't tend to stay low and, go low and stay low. It tends to sort of vacillate between. So it's very, I've been doing this long enough where I've had patients that come in, in adolescence having anorexia and come back 5 years later being overweight and struggling with binge eating. This is a pendulum. So I think that's an important thing to keep in mind. There was a study looking at, people of normal weight over like a 30-year period of time. Something like 95 or 97% of them had never dieted. They ate regularly, they ate consistently, and were generally just mindful about what they eat. So that's the ideal. The ideal is not to be 5, 10 pounds underweight, right? If you want to maintain a reasonable and healthy weight, you really do want to be in kind of a good set point for your body. So I think although she might sort of maintain this skeletal sort of appearance now, another risk other than the osteoporosis is maybe that pendulum swinging the opposite direction. We call it sort of a transdiagnostic understanding of an eating disorder. I always say if you sign up for one, you sign up for all of them. If you start restricting, it's not a question of if, it's a question of when. You will start binge eating often. You're at very high risk for that, and then that might cycle into purging. I just had a patient that was admitted at the end of last week who, again, very similar, kind of keeps herself at this 10 pounds below normal weight, and now a year into things, now she's started purging when she gets sort of freaked out about what she's eating, or all of a sudden eats a little bit more and feels full because she's sort of chronically underfed, and then she starts purging because it's relieving that full feeling. So it's a cycle. These things sort of very much transition from one to the other.
Just a question about the occurrence of eating disorders in children who have other chronic illnesses, heart disease, cancer, things that have kind of led to a family focus maybe on eat more, you'll get better, eat more. And what happens 5, 10 years out?
Well, I think that brings up an interesting question. We see this a lot with diabetic kids. They've sort of gone through that fluctuation in weight that oftentimes goes along with being initially diagnosed with diabetes, or they had a DKA episode, or they've sort of started insulin and gained a lot of weight, and then have concern about that and start restricting. Again, I think it goes back into, and you mentioned a little bit about the focus and the sick role. I think that's something to kind of keep in mind too, that a lot of times these kids that are sort of used to having problems or being ill, sometimes an eating disorder can sort of fill that spot too. They're continuing to get some attention for what's going on. And that can be, again, it's not seeking attention, but as you all know, probably the important thing with kids is what's reinforcing, right? What are the things that are happening that are continuing to sort of reinforce that behavior? It's a good question, and I think it goes back to what is their, again, my default is to go back to what is their eating pattern, what are the things that are contributing to what's going on with their eating, either if it's overeating or undereating. I see a patient this week who's a 9-year-old who got diagnosed with a peanut allergy, and you know how, what's the word, focused on allergies and peanut allergies our society has sort of become. This has sort of shifted her into not eating at all because she's so freaked out. She's only eating, liquids and things like that because she's so concerned about having a reaction to a peanut allergy. So I think, I guess the simplest answer is really focusing and looking at what is their eating pattern like, what's reinforcing in terms of either overeating or undereating.
Still have the room if anyone else has.
Yeah, if anybody has questions, just let me know. Thanks.